responding to a 7 Delta for a house explosion with an active fire. There are 3 patients trapped inside. You are currently the only unit attached.
Okay, so pulling up on scene, I'm going to put on my PPE and assess the scene for any obvious hazards. You said it was a structure fire. Is there a fire crew on scene managing the fire?
Correct. There is a fire crew on scene currently managing structure fire. You also note that there is structural collapse to the home as well as exposures.
Okay. How many patients do I have?
There are 3 patients on scene.
Okay, 3 patients. So I'm going to request additional resources. Due to there being 3 patients, I want at least 2 more ambulances. Fire is already on scene. I will request RCMP to respond as well. And due to the mechanism of injury, I want to have STARS on standby. Mechanism of injury obviously being house explosion with subsequent structure fire. So as I'm approaching my patient, I just want to take note of my general patient appearance. So patient's age, patient sex, patient position, date, time, weather, and just what my patient generally looks like.
So you have a young adult male. His weight is average. He is lying supine in a Stokes basket in the backyard of the home. He has been extricated by fire on scene. You note that all of his clothing and hair is completely burnt off. The patient has obvious full thickness burns to a significant portion of his body, including his face. The patient's face is black. He appears to be in significant distress. He is writhing and screaming in pain. You do not note any deadly bleeds on approach.
Okay, well, as I approach my patient, the first thing I'm going to do is I'm going to delegate Trenton to come and hold manual C-spine.
Sir, please don't move.
Now I'm going to assess my patient's general level of consciousness. I understand he's screaming in pain, but is he responsive to verbal stimuli? I'm going to ask him his name. Sir, can you tell me your name?
Patient does respond to verbal stimulus. He is only oriented to person.
Okay, so I'm going to do an assessment of my patient's airway. He is talking to me, but I want to look inside of his mouth to see if I can identify any obvious airway obstructions and any pooling edema in his posterior oropharynx.
So the patient is screaming in pain, very hoarse, and is coughing frequently. On further assessment of airway, you know that the patient's tongue has the appearance of a burnt marshmallow. He also has significant airway edema, and you note audible stridor.
Okay, I'm going to assess my patient's breathing, so I'm going to assess rate, rhythm, and depth of respirations.
So you know that the respiratory rate is difficult to assess due to patient distress. It is approximately 30 breaths per minute, irregular, shallow, and labored.
Okay, so due to the shallow, irregular, labored respirations, I'm going to delegate Sarah to try and assist the patient with ventilations using a BVM with 100% supplemental oxygen.
So patient will not accept a BVM.
Okay, so next I'll get Sarah to just apply a non-rebreather, 15 liters a minute, attached to 100% supplemental oxygen. While she's doing that, I'm going to assess my patient's radial and carotid pulses. As well, I'm going to assess the patient's skin, color, condition, and temperature. And while assessing the radial and carotid pulses, I'm going to assess for rate, rhythm, and quality.
So there are palpable pulses present. You know that the skin's patient is black and charred. The rate is 120, regular, and weak.
Okay, so due to the patient's significant mechanism of injury, significant airway burns, and what appears to be full thickness burns to a significant portion of his body, I'm going to designate this patient as critical, and he's going to be a load and go, and I'm going to perform a rapid primary assessment. Starting at the head, I'm going to visualize for deformities, contusions, abrasions, pain, penetrations, burns, tenderness, lacerations, and swelling. I'm going to palpate the head for tenderness, instability, and crepitus. I'm also going to palpate the neck for tenderness, instability, and crepitus. I'm going to assess the neck for obvious signs of trauma, jugular vein distension, subcutaneous emphysema, and tracheal deviation.
You note full thickness circumferential burns to the head and the neck. Patient's nose and ears appear to be burnt off. There is no JDG. Trachea is midline. Tongue has the appearance of a burnt marshmallow. No tenderness to the head or the neck.
Due to the mechanism of injury, I'm going to delegate Sarah to apply a cervical collar while I move down to the chest and continue with my initial assessment. So I'm going to assess the chest. I'm going to visualize again for decap ITLS and any obvious signs of trauma. I'm going to palpate for tenderness, instability, and crepitus on the ribs and along the sternum. I'm going to see if I can identify any paradoxical motion, and I'm going to check for chest symmetry. Additionally, I'm going to auscultate the apices for the lung sounds, and I'm going to listen for any muffled heart sounds as well.
You note full thickness circumferential burns to the entire thoracic region. Chest rise is symmetrical. There is no paradoxical movement. No tick on palpation. Breath sounds are diminished to the apices with audible wheezing. Heart sounds are normal, and there is no subcutaneous emphysema.
Moving on to the abdomen, I want to assess the abdomen again for decap ETLS and any obvious signs of trauma. I'm going to palpate the 4 quadrants for distension, rigidity, and tenderness. And I'm also going to evaluate to see if I can identify any eviscerations, or any kind of penetrating trauma.
You note full thickness circumferential burns. The abdomen is soft and non-tender on palpation. No other injuries are noted.
Moving on to the pelvis, I'm going to visualize the pelvis for obvious signs of trauma and decap ETLS. And then I'm going to palpate the pelvis for tenderness, instability, and crepitus by putting downward pressure on the iliac crest.
Full thickness circumferential burns are noted to the entire pelvic region. Patient genitals have been burnt off. Tenderness, instability, and crepitus on palpation are present.
Due to the tenderness, instability, and crepitus on palpation, I'm going to delegate my firefighter to hold manual stabilization. Moving on to the lower extremities, I'm going to start by assessing the upper portion of the lower extremities, again for any obvious signs of trauma and decap ITLS. And then I'm going to palpate the long bones for tenderness, instability, and crepitus.
Full thickness circumferential burns are noted to both legs. No tick on palpation.
And then quick assessment of the lower part of the lower extremities and the upper extremities. I'm going to assess for, again, any obvious signs of trauma, tenderness, instability, and crepitus. And I'm also going to check distal pulses. So check circulation, motor function, and sensation at the pedal pulses, and then check circulation, motor function, and sensation at the radial pulses.
Full thickness circumferential burns are noted to all extremities. There is no tick on palpation. The patient cannot feel but can move his fingers and toes.
Okay, so up until this point, we've done a full primary assessment of our patient, excluding the patient's back. However, that is something that we're going to assess as we move the patient. So the way that we're going to move this patient, due to the instability of the pelvis and his critical condition, is we're going to scoop him using a scoop stretcher, and we're going to put him onto a prepared stretcher with a burn sheet and a prepared pelvic splint. While we transport the patient to the stretcher, I want to do a quick assessment of the patient's back, assessing for any obvious signs of trauma, deformities, contusions, abrasions, pain, penetrations, burns, tenderness, lacerations, and swelling.
Full circumferential burns are noted to the back. No tick on palpation with the back.
Okay, so Sarah and I are going to do the lift. We're going to do the lift on Trenton's count because he's still holding manual C-spine. Okay, on your count, Trenton.
1, 2, 3.
Okay, so at this point, we've completed a full primary survey on our patient. The way that we transported our patient from the Stokes basket onto the stretcher was by using a scoop. The scoop was appropriate due to the pelvic instability, and it gave us an opportunity to do a full assessment of the patient's back, assessing for any obvious signs of trauma and obvious signs of trauma, including tenderness, instability, and crepitus. What we found was full thickness circumferential burns to the patient's posterior, same as the rest of the patient's body. Now that we have the patient on the stretcher, we move the patient into the back of the ambulance, where we're going to take the scoop off. We have a sterile burn sheet and a prepared pelvic immobilization device. So once we get the patient into the back of the ambulance, I'm going to delegate my partners to secure the patient's head to the stretcher for spinal motion restriction, and also apply pelvic binding due to the instability of the patient's pelvis. So now that we're in the back of the ambulance, Sarah and we're going to bind the patient's pelvis, doing the pre-hospital method using this sheet. So we're going to measure from the top of the iliac crest down to just below the greater trochanter, while our firefighter is holding manual stabilization. So I'm going to pass this over to Sarah. Sarah's going to pass her side to me. We're going to pull tension, and then we're going to twist. And then we're going to twist one more time for friction. And then we're going to secure the pelvic bind in place using these hemostats. So one on the bottom here. One on the top there. One there. And then one there. And then now that I have this in place, I'm going to delegate Sarah and my firefighter to help Trenton secure the head of the patient to the stretcher for spinal motion restriction, and then I would like to be off scene. Since we moved into the back of the ambulance, I'm going to do a full reassessment of my patient, starting to see if I can identify any obvious subjective changes. We're off scene. Now I'm going to do a reassessment on my patient. I'm going to delegate Trenton to get a full set of vitals on the patient while I do the reassessment. So I want a blood pressure, I want a heart rate, I want a respiration rate, I want a BGL, I want a temperature, I want an end tidal, I want a full ECG. And then I'm going to start doing my reassessment. So first I'm going to see if I can identify any subjective changes with my patient.
There are no subjective changes.
Okay, now I'm going to move on and assess the patient's overall level of consciousness. Is my patient still alert to verbal stimuli?
Yes.
He appears to be in quite significant distress. I know he's hard of hearing, but is he able to respond to my questions?
Patient response is only oriented to person due to his lack of hearing, will not answer any other assessment questions.
Okay, so I want to do another assessment of the patient's airway. So the patient is talking to me, so I'm anticipating the airway is open. However, I want to make sure the airway is clear, so I'm going to visualize inside of the patient's mouth to see if I can see any obvious obstructions. And again, worsening edema or any kind of pooling discharge in his posterior oropharynx.
The patient is screaming in pain, is very hoarse, and is coughing frequently. On further assessment of any obstruction to the patient's airway, you note that his tongue has the appearance of a burnt marshmallow and significant airway edema. The patient also has an audible stridor.
Okay, so we have worsening airway burns. Next, I'm going to assess my patient's breathing. So I want to assess rate, rhythm, and depth of respirations.
Patient's respiratory rate is difficult to assess due to his level of distress. His rate is approximately 30 breaths per minute, irregular, shallow, and labored.
Okay, I want to delegate Trenton to try and assist this patient with a bag valve mask with 100% oxygen at 15 liters a minute. Will the patient accept the BVM?
Patient will not accept the BVM.
Okay, then we'll continue with the non-rebreather. And then I want to assess patient circulation by assessing radial and carotid pulses for rate, rhythm, and quality, also assessing patient's overall skin color, condition, and temperature.
Radial pulses and carotid pulses present. Skin is black and charred. No deadly bleeds are noted. The rate, rhythm, and quality is 80 beats per minute, regular and weak.
Okay, I've completed my rapid reassessment exam. We're still getting a set of vitals. Now I want to gather a sample history. So signs and symptoms, we have a patient with significant airway burns, pelvic instability, and what appears to be full thickness circumferential burns to 100% of his body. Additionally, I see if my patient has any allergies.
No known allergies.
Does he take any medication?
No prescribed medications.
What's his past medical history?
No known history.
And last oral intake?
He states approximately breakfast time.
And what were the events leading up to this incident?
Patient states that he remembers lighting the pilot light for the furnace. Next thing he remembers is being extricated by fire on scene.
Okay, so what we've identified again, significant airway burns, pelvic instability, and significant burns to 100% of his body. So for treatment, first thing I want to do is I want to stop the burning process. So I'm going to delegate one of my partners to apply room temperature normal saline to the patient's burns for 1 to 2 minutes. Once we've stopped the burning process, I want to apply sterile dressing to as much of the burns as possible to potentially reduce contamination. What are my vitals?
Her pulse is 88, weak and regular at the radial. Your respiratory rate is approximately 30 breaths per minute, irregular, shallow, and labored. Blood pressure is 90/70. Sats are 100% on 15 liters through the non-rebreather. The 4-lead ECG shows sinus tachycardia. His end tidal is 28 millimeters of mercury. Temperature is 35.2 degrees Celsius, GCS of 15, and a high level of discomfort and pain.
Okay, so I also want to get intravenous access. So I'm going to delegate one of my partners to start an IV if they can. If not, let's start an IO, and we'll just give the patient a little bit of fluid to try and restore peripheral pulses. Due to the smoke inhalation, I want to continue supplying 100% oxygen to this patient due to a potential for carbon monoxide and cyanide poisoning. And then I want to reassess the pelvic, the device that we use to secure the pelvis, and it still appears to be and then due to the wheezing that I identified, I also want to delegate Trenton to get a nebulizer ready so we can give nebulized Ventolin to this patient so we can get some bronchodilators on board because of the audible wheezes. Okay, now that we've completed all of our interventions, I'm going to start doing my secondary exam while my partners are applying dry, sterile sheets to as much of the patient's full thickness burns as they can. Because we've given bronchodilators and started an IV, first I want to start with a reassessment by assessing my patient's level of consciousness. Is my patient still responsive to verbal stimuli?
Yes.
Okay. Does he know where he is right now?
Patient is only oriented to person, is unable to respond further due to difficulty hearing.
Okay. Reassessment of the patient's airway. I want to look inside. He's talking to me, but I want to see if there's any worsening obstructions.
Patient is screaming in pain, very hoarse, and is coughing. The patient's tongue still has the appearance of a burnt marshmallow, significant airway edema, and audible stridor.
Okay, assessing the patient's breathing again for rate, rhythm, and depth.
Rate is approximately 30 breaths per minute, irregular, shallow, and labored.
Okay, so we have a combi vent going. We're giving bronchodilators to try and open up this patient's airway a little bit. Will the patient accept a BVM?
The patient will not accept the BVM.
Okay, so moving on to assess circulation again, assessing circulation at the radial and the carotid for rate, rhythm, and quality of pulses, also assessing skin color, condition, and temperature.
Pulses are present. Skin is black and charred with a rate of 80, regular, and weak.
Okay, and then doing a secondary head-to-toe examination. So starting with the head and the patient's neck, again, assessing for any obvious signs of trauma. I also want to assess the patient's pupils to see if they're equal and reactive to light. I want to palpate for any new signs of tenderness, instability, and crepitus, and see if I can identify any unusual odors on the patient's breath. Additionally, I want to assess for jugular vein distension and any tracheal deviation or subcutaneous emphysema.
No changes are noted. Patient pupils are 3 millimeters bilaterally and furrowed.
Okay, moving on to the patient's chest. I want to visualize the patient's chest, again, for any obvious signs of trauma, decap ITLS. I want to palpate the tenderness and stability and crepitus along the ribs and along the sternum, and see if I can identify any asymmetrical motions, paradoxical motions, and now I'm going to auscultate at both the apices and the bases, and I also want to listen to see if I can identify any muffled heart tones.
No changes are noted on exam.
Okay, apices, bases, muffled heart tones. Moving on to the abdomen, again, I want to assess the abdomen for any obvious signs of trauma, decap ITLS, any eviscerations, any penetrating trauma, and then I want to palpate the 4 quadrants for distension, rigidity, and tenderness, or any obvious pulsating masses.
Abdomen is soft, non-tender on palpation. No other changes have been noted.
Okay, and is my patient nauseated? Has he vomited?
Patient denies.
Okay, moving on to the pelvis. I want to reassess the pelvis for any obvious signs of trauma. I understand he has tenderness, instability, and crepitus, so I'm not going to repalpate the pelvis, but I am going to reassess the patency of the pelvic splint that we've applied.
Splint is patent. No changes are noted. You note that the patient's genitals have been burnt off, but there is no blood at the urethra or rectum.
And no obvious signs of priapism. He doesn't have any genitals. Moving on to the lower extremities, I'm going to start by assessing the upper extremities. Any obvious signs of trauma, palpating for tenderness, instability, and crepitus.
No changes noted.
Moving on to the lower part of the lower extremities, again, obvious signs of trauma, tenderness, instability, and crepitus. I'm also going to palpate for any pedal pulses, circulation, motor function, and sensation by palpating pedal pulses, having the patient push down on my hands and pull up on my hands.
Patient has altered sensation due to the burns, otherwise TMS is intact.
Okay, moving on to the upper extremities, I'm going to reassess the upper extremities, see if I can identify any obvious signs of trauma, decap ITLS, and I'm going to palpate along the long bones for tenderness, instability, and crepitus. And I'm also going to assess circulation, motor function, and sensation by assessing the radial pulses and having the patient squeeze my hands and seeing if the patient can feel me touching his fingers.
No changes are noted. No sensation is present.
Okay, secondary assessment complete.